Welcome to the 340Banter podcast. In today's episode, we'll be discussing entity-owned pharmacies. Recently, many covered entities have wanted to investigate opening an entity-owned pharmacy, but don't know where to start. We'll discuss what you should think about before you open a pharmacy, as well as tips to help it succeed once it is opened.
You know, with all the manufacturer restrictions we've been seeing around contract pharmacies, we've really seen covered entities take a significant hit to their 340B savings, and it's really impacted patient care with layoffs and different service lines needing to be trimmed down. And one of the things that we're seeing a lot is covered entities look to entity-owned or in-house pharmacies, either starting a new one, adding to an existing one, or optimizing ones that they already have to try to make the most of the 340B savings within there. Logan, working within our pharmacy services service line, I was wondering if you could kind of talk to us about what you're seeing as you're walking health centers through adding their own in-house pharmacy.
Yeah, I really think it's become a very popular service line. We're having more and more people come to us asking us if it's possible, and I think that that's the first step. Is a entity-owned pharmacy right for every covered entity? Probably not. Unfortunately, I know it's really hurting some of the smaller FQHCs, but you have to have that volume of prescriptions to really make it valuable. But we're talking to health centers all over the country that are really seeking to see if it's right for them.
What are things, aside from having a smaller organization with just smaller script volume in general, what are other things that might contribute to an entity-owned pharmacy maybe not being the right pick for a certain organization?
I think the other thing is payer mix. So we commonly, when we're looking at that, we're pulling for health centers, we're pulling UDS data because we can pull that payer mix right off of HRSA's website. But it's really
hospitals would have the same stuff in their cost reports as well. Then
exactly.
Right.
So it's important to know that for a couple reasons. One, you're going to want to know how many uninsured patients you're going to have, because really we're not making money on our uninsured patients. We're there to provide a service, and the goal is to break even, maybe pay for the time of the pharmacist to dispense that prescription. But even some health centers don't do that. They subsidize that cost for their uninsured patients. But that makes a burden on the health center financially. The other thing is really knowing the Medicaid rules in your specific state. Some states, like mine of Ohio, we preserve our 340B savings on our managed care Medicaid claims. So it allows us to be reimbursed at a level where we still maintain those savings. Where what we're seeing in a lot of states is that even managed care Medicaid is being reimbursed at a fee-for-service logic.
Right.
And that's the acquisition cost of the drug plus a professional dispensing fee. And while that's pretty much a break even, which isn't bad, but it makes it hard if you have a very high Medicaid percentage to keep the pharmacy sustainable.
Doesn't give you a lot of buffer room. Also, I feel like, not all states' professional dispensing fee is equivalent to the overhead, the admin fee that you typically would assign to a prescription just as part of your usual and customary billing in the pharmacy.
Right. The cost of filling a bottle of air, right, is typically higher. Another thing too is that even if you're a small health center, it doesn't mean that the pharmacy is not right for you, right? Now, is it more likely that it may not be for you? Yes, but based on your, we kind of talked based on your payers from a perspective of it not being financially viable. Mm-hmm. Also, based on your payers, we can find that it is financially viable at a small health center.
In addition to the payers, it's also what specialties you have, because some specialties come with just drugs that typically have a higher 340B savings. So if you have just primary care, it may be a little challenging if they're pretty much dispensing generic medication. Right. But if you're doing HIV care, you may be able to sustain a pharmacy program with less prescription volume.
Thing I think that's really cool there is that that becomes kind of mutually sustainable. So your specialties where the medications associated with them might have a larger 340B savings. That then helps the organization reinvest in treating that condition or that disease state, or adding in services for another one. So we've seen a lot of organizations through their 340B programs and through the savings generated just from their entity-owned pharmacy be able to add things like hepatitis C treatment or HIV treatment or more mental health services, or homeless shelter healthcare. And so I think that, those drive the prescriptions that might help the organization increase 340B savings. And then that 340B savings is often directly invested right back into expanding access to care that's really hard to get, particularly in some rural areas.
We're seeing a lot of health centers also, you mentioned hepatitis C, we're seeing health centers be able to start clinical pharmacy interventions as well through that, because clinical pharmacy services aren't always reimbursable. So that's a great way to use your 340B savings. And it's a symbiotic relationship. So you're, once you start a clinical pharmacy program that's getting hepatitis C treatment out there, one, it's great clinically because you're curing a viral disease for the patient.
You're curing it.
And two, it's creating more and more 340B revenue, which allows you to keep funding those services.
And even outside of specialty, I think clinical pharmacy brings a lot of value and has that, a mutual connected relationship with the in-house pharmacy. The more my patient gets familiar with our pharmacy team, we see a lot of health centers will kind of rotate where, you have certain days you work in the pharmacy, certain days you work on the clinical side. And not that you don't steer prescriptions, you're not trying to steer a prescription, but the patient is more involved with your team now. And so the likelihood of them, if they see your pharmacist on the clinical side, and then, next week I'm going to be able to see them inside the pharmacy when I pick up my medication, I think you have a likelihood of higher capture rate.
Yeah.
And just
increased level of trust.
Right.
And along with the steering, I think that's a good point
Or
to
lack
talk
of.
or lack of.
Lack of steering.
That discussion, I think it's a good point to discuss, because that scares a lot of health centers, because you're not prohibited to steer your patient's prescriptions to your entity-owned pharmacy. But I think it's important to take a step back, think about pharmacy the way you think about every other specialty.
I want to revisit, because I think you said you're not prohibited from steering your patients to your own pharmacy. Yeah. And you don't want to remove, we're not saying that you're removing the patient's choice in where to fill their prescription. As opposed to steering, we're more providing education about the additional services and level of care they would get from your pharmacy. Yeah. Sorry, I misspoke.
Taking us off the rails here, Logan.
So I think there, if you think about it as another specialty, our providers are not concerned with recommending a cardiologist that works really well with them, that they have a good relationship with. Does the patient have to use that cardiologist? No, they can go to a different cardiologist. They can say, I want to use this other cardiologist, but that's not considered steering. That's explaining a clinical benefit and a communication benefit to using that cardiologist. I think the same goes for pharmacy. Your medical providers have a lot of trust with their patients, so they can communicate that and say, these are the clinical benefits to using our entity-owned pharmacy.
Yeah,
I think that point is a great one to build on, because we talked about the benefit from the 340B savings, reestablishing those 340B savings within an entity-owned pharmacy, particularly if you're feeling that loss from the contract pharmacy restrictions. But there are so many benefits to entity-owned pharmacies outside of just the 340B savings and the financial aspects. And I think it's worth discussing some of those, because that can help the decision-making process on if an entity-owned pharmacy is right for a certain organization.
Yeah, and I think that kind of, the start of that is more of a family setting almost, right? Because rather than I'm going to see this corporation, and then I have to go get this at this corporation. When it's all in one family, leadership is the same. They should be not necessarily operating, but the way they do business should be the same. The mindset of what we stand behind, how we're going to provide our support. And not that independents do a great job at supporting their patients and take care of the community, but it makes everything a little bit simpler. So, and I know, I think you're caveating more of, I don't know if caveating is the right word, but you're going more into the patient care side because there's benefits from just patient care. But I think just from a personal relationship side, it's better to deal with one entity. It feels more homey. I don't know if that makes sense.
I mean, I'll say from the patient care side and the better connection side of things, by the pure nature of being in the same building as the health center in many cases, and having access to the same medical record,
right?
It streamlines so much. Having worked as a retail pharmacist, both in a pharmacy within my FQHC and also in a retail pharmacy outside of the FQHC, having to correct a prescription or call about dosing to clarify something or needing to change a prescription because we have information about an allergy that maybe the physician didn't have. Being in the health center makes that so much more seamless, just from the pharmacist workflow point of view, but also from the patient's point of view. It's so frustrating as a patient when you're already sick, already having a really bad day, go to a pharmacy and they say, there's a problem with the prescription. We have to talk to your provider. And then it takes them 2 days to get clarification and get that back. And you're already feeling terrible. You're already having to drive to multiple places, what have you, not in the medication when you need to be. And in the pharmacy attached to the health center, you can call the provider's MA that's right down the hall. You can go check in the medical record to see what they discussed during the visit. Maybe there was a reason for choosing this specific thing, even though there's a documented allergy. They talked more about what the reaction was and this medication's okay now. Or I could just go down the hall and ask them, grab them on their way out of their pod, from their desk or on their way into a visit. Hey, can I clarify a prescription real quick? And we're able to help that patient before they've left the building the first time.
Right.
And actually get that taken care of.
I would stand outside the exam room until they came out. And catch them. Another benefit, especially to health centers, and I'm sure it applies to the hospital space as well, are your value-based care agreements. That's becoming more and more important for health centers, is that you're being paid in a different manner. Instead of a fee-for-service logic, you're getting paid based on performance. And almost every one of those measures is directly or indirectly impacted by pharmacy care. So by getting a patient adherent on something like their statins, it's going to decrease their risk for heart attack or stroke. And by really putting a focus on that entity-owned pharmacy, you're going to increase adherence to drugs and have better patient care. And that will indirectly provide more revenue for the health center by improving those performance measures.
Right. And then, pharmacy is the retail side of pharmacy is not what it used to be. It's very difficult. And so if we look at it from a business model, because of 340 being an in-house pharmacy, we essentially have more time to spend with the patient, right? Our pharmacists have more time to interact with that patient because independent retail pharmacy is a very tough game, right? They have to squeeze every penny out of everything they can get. Now that I'm not, they love their communities. They go above and beyond for their patients, but at the same time, they also have to make business sense. They have to be able to pay their salaries. They have to be able to pay their overhead. They don't get federal grants to help supplement that like the FQs do. But even those grants are really for the medical side. So the 340B allows us to spend more time inside that pharmacy and get those interactions with those patients and make them feel comfortable with us.
And the contract pharmacy restrictions are hitting them too.
Right.
Yeah.
So it's not just the impact to the covered entity, but it's also the impact to our partner pharmacies. So they're getting hit from another direction now. And I just think that that's somewhere where we're able to help those more complex patients. One of the things one of my providers, it took her a while to get on board with the entity-owned pharmacy when I was at my health center. But one of the things that really spoke to her was that we were helping her patients when there was an access issue. So maybe it was insurance wasn't covered or it needed prior authorization. And she said, I don't know how many of my patients, when they walk out the door, don't fill their prescription.
Yeah.
And that they can help if they know, but they don't know.
Right.
And
that was a huge benefit for her and really sold her on the entity-owned pharmacy.
I think one of the other cool things that you can do facilitating when you have, or that you can facilitate when you have your entity-owned pharmacy is prescription assistance programs, some of those bulk replenishment medications. So if you send a patient out for a prescription, they go to a retail pharmacy out in the community, can't afford it, and they come back to you and say, I can't afford this medication. There are access navigators within the health center who can help them look into the prescription assistance programs. But again, that's an additional delay in care, and it relies on the patient coming back and asking for help. Versus if you are managing it within your own entity-owned pharmacy and you have the ability to contract with some of the prescription assistance bulk replenishment programs, once you qualify patients for those, they can come get those prescriptions for free from your pharmacy, just like everyone else. They're not waiting to get things in the mail. You're not relying on the patient to come back to the health center and seek out additional support in getting affordable medication. So it's really nice to be able to pull that in, take away any stigma from having to go through a different access point, take away an additional barrier to receiving care by letting them get it at the pharmacy just like they would otherwise. See the same thing with vaccines, increase a lot of access to, vaccine care in general when the pharmacists are able to provide them. Particularly, I know in cold and flu season, our walk-in clinic would just get slammed with vaccine requests, which was great. You want your community vaccinated,
right,
to protect, but we just, a lot of times our health center staff didn't have the capacity for it, and being able to increase that capacity within the pharmacy so they're still in the same building, you're not sending them away somewhere else. Being able to do that was very meaningful, I know, for us.
Another opportunity could be pharmacy students.
Yep.
It gives you the opportunity as a pharmacist to be a preceptor for pharmacy students in their final year of school. And that brings an extra person into the health center. That person can immunize, that person can work through the different pharmacy things. It doesn't mean it's free labor because it's some work on the preceptor.
It's a lot of work.
But it does allow you to expand your services, and students are a great way to bring fresh eyes into your pharmacy.
So I think we've talked a lot about the kind of the decision points that might help you get to is an entity-owned pharmacy right for your organization, and then what additional value and benefits can you derive from having your own entity-owned pharmacy. And I'd love if we could kind of wrap the conversation up by just touching on what conversation points or what partners you need within the leadership, the organizational leadership, to move an entity-owned pharmacy forward, because it is not a pharmacy specific, it's not in a silo.
right.
There's so many other parts of the healthcare system and the health center that play into that. So maybe you can talk a little bit about, particularly because you come from a background outside of pharmacy, how important those conversations are in discussing the viability for an entity-owned pharmacy.
Yeah, even past viability, it's like how do you maintain it as someone who doesn't understand pharmacy and how it operates? I think one of the big things that I see is, and again, this is just because that's where my best understanding is the accounting side.
Yeah.
So, when we go into in-house pharmacies and, there's almost a disconnect. And I feel like we've had conversations about this before, where sometimes you go into a health center and it's almost, though they're the same, it's almost like they're separate entities, right? Like the pharmacy exists over here. They're in the same building, same employer, same management. However, like they have their own thing and then medical has their own thing. And I think that from a management perspective, you want to put things in place to kind of bridge that gap. And that could be different committees that you set up to have those interactions between departments.
Yeah.
But like my big thing is the accounting. The accounting's kind of a mess. And I've gone into some health centers where they're like, oh, well, we make the pharmacy kind of prepare that for us. And I'm like, but that's not what they understand, and that's not what we're
Yeah.
paying them to do. And that
And
really
we're not good at.
right. And so I feel that accounting, your accounting department needs to understand how to run a report. Again, do they need to know the clinical benefit of this drug versus this drug? Probably not. But
Understand some of the nuances of the 340B program.
yeah,
at a high level.
You need to know some things. You need to know what's allowed. You need to be able to catch that. But someone in accounting should know how to run a report out of the filling system and be able to take that and understand what the data is telling them, right? And further than that, not just understanding what it's trying to tell me, understanding when it's not right. And that's a hard thing. You don't know, because in accounting, we're used to trusting numbers and what numbers come out of the system come out. But for some reason, pharmacy filling softwares and accounting departments kind of butt heads quite a bit. So I think it's super important for your finance team to understand that, so that you're not having problems at year end when you have your single audit come in and, and well, I don't know why it says that number. Well, that's what the system told me. You need to understand that, hey, that's probably not the right number. You need to have enough understanding of your pharmacy as management to be able to get a report and say, that doesn't seem right.
I think that that's really important when you are starting up an entity-owned pharmacy, so that you have that understanding and you're building a solid base. But I think it's so important even once the pharmacy is up and running, and having your finance team understand, like I said, a little bit of how the 340B program works and how the different pieces interplay. Because I know that I've definitely had to deal with the perception of the 340B program or the pharmacy program being like the goose that lays the golden eggs.
Right.
And oh, well, this has helped. Because honestly, health centers typically would operate in the negative without their 340B program.
Absolutely.
And because of that, each year coming back and saying, okay, well, we had this, we need to add this service next year, so we're going to need your department to make this much more money. And having to then tie it back to, you said accountants trust numbers, so bring it back to, okay, here's how many visits we have. Right. Here's how many prescriptions we generate out of a visit. Here's how many prescriptions we're capturing out of our, in our pharmacy. Realistically, this is about what we can capture, and it's not going to infinitely grow, and being able to connect those dots and have your finance team, your budgeting team understand that moving forward as well, so that you're having realistic expectations within your pharmacy is really important too.
I think thinking about that whole leadership approach, one of the things when I've talked to C-suite, especially when they're new to pharmacy, either getting implementation going or they just opened a pharmacy, or maybe that they're struggling. They've had one for a while and their pharmacy is struggling. One of the things I like to tell the C-suite is the pharmacy staff are the least impactful on the capture rate. Can they be impactful? Yeah. If they're giving poor service to their patients, then it's going to negatively impact it. But really the most important piece in most health centers, at least, and I'm sure this applies to other covered entity types, is that medical provider. Right. They've developed that rapport, that trust with the patient, and they follow their recommendations. So if they're talking about the pharmacy, then it's going to succeed. But really, it needs to be an all-staff approach.
Yeah. And again, it's a trickle-down thing, right? So you need C-suites buy-in. You got to have it, because if you have C-suites buy-in, they can help you get medicals buy-in. If you don't have C-suites buy-in, you have a problem. And it, especially for an FQ, right? We get federal funding because we provide services that are expensive for us to provide, knowing that we may be serving patients who don't have an ability to pay the expensive costs. So we're writing that down. And so in the pharmacy is really one of the, there's a few, but one of the only areas where you can typically generate income or profit versus medical or dental or behavioral health. And so to me, it just would make, I think everyone from the C-suite should buy in, right? Because this is an area where we can, and we should show it some love, and we should show some we should be observing this and have discussions around what's going on in the pharmacy and fine tuning that pharmacy to operate efficiently. Because by operating efficiently, one, from a business perspective, you're able to produce income, but two, you're getting better patient care. I mean,
Yeah.
the more efficient we can be in any workflow, we get to produce a better product, right?
Yeah. So, I mean, so you're pulling in, we already talked about finance, you talked about clinical leadership. You've also got quality, the quality of your patient
Mhm.
care and meeting your value-based measures. We've got compliance and legal because of the nature of
Right,
a
right.
government program. I think that it touches so many different aspects of
Mhm.
the covered entity of the health system that buy-in is really important. And so education is really important because you don't get buy-in without people understanding. So I
Absolutely.
think
Yeah.
if we were to pick kind of the one major thing to deliver to your organization, if you're thinking about an entity-owned pharmacy, it would probably be educating and talking with your C-suite and understanding what values they have that a pharmacy would bring.
Absolutely. Absolutely.
I agree completely that education component. One of the things when we're talking to people who've just opened a pharmacy because they're trying to grow their pharmacy business, is try to get included in orientation. So you talk to every provider when they come on staff. So they
Yeah.
understand how the 340B program works. So they understand how the entity owned pharmacy works. Because the better they know how it works, the more engaged they're going to be.